Good morning. Welcome back to Open School. I'm Dr. Andrews, Professor of Medicine, consultant neurologist. Acute liver failure. This is an interactive lecture based on up-to-date AASLD and ASL guidelines. The objectives are to define acute liver failure using the criteria, understand the subtypes, know the major causes, key pathogenesis, major clinical features, and how to approach. What is the definition? Acute liver failure is severe liver injury plus evidence of impaired synthetic function, as evidenced by INR more than 1.5 plus altered mental status in a patient without cirrhosis. So this occurs in patients without an underlying liver disease, where there is liver injury, usually evidenced by jaundice, impaired synthetic function, usually we look for the INR, plus patient has got features of hepatic encephalopathy. What's the duration? Different guidelines say different, but usual cutoff is taken as less than 26 weeks from the onset. Acute liver failure has got many subtypes. One is the hyperacute. That is, it occurs within 7 days, the disease. Acute is 7 to 21 days. Subacute is more than 21 but less than 26 weeks. In the clinical presentation, there is little difference. The acute presents with more of cerebral edema, that is features of mental status abnormality. And subacute presents with more of features of portal hypertension. They may develop ascites, splenomegaly, kidney failure, etc. And the prognosis also varies between these two. What are the common causes? Western countries, it is acetaminophen, more than 40 or 46%. Drug reactions, drug-induced liver injury is a very important thing. In underdeveloped countries, viral hepatitis A, B, E, HSV, and CMV also contributes. Autoimmune hepatitis, Wilson's disease, ischemic hepatopathy, toxins, especially mushrooms, Amanita phalloides, pregnancy related acute fatty liver pregnancy, HEP syndrome, sometimes malignant infiltrations. As mentioned, in Western countries, it is acetaminophen, that is paracetamol. In many other places, daily drug-induced liver injury is common. In Asia and Africa, as mentioned, it is viral hepatitis. Hepatitis C virus, high risk in pregnancy. What is the pathogenesis? First and foremost, there is massive hepatocyte necrosis, which leads on to detoxification failure. Ammonia is converted to urea in the liver. The production of ammonia is by the enterocytes and also by bacteria from the urea that enters intestine by bacterial enzymes. So this leads on to cerebral edema because ammonia in the astrocytes converted to glutamine, and this leads on to osmotic effect leading on to cerebral edema. In addition, there is systemic inflammatory response. Nitric oxide and other vasodilators are there. Finally, it leads on to multi-organ failure. Prognosis varies with different causes. Let us look into what are the clinical features. First, there is massive hepatic dysfunction, rapid jaundice. The synthetic function is affected, especially the coagulopathy. The INR becomes more than 1.5. Patient develops mental status abnormality, that is encephalopathy. And cerebral edema is more common in the acute setting, kidney failure and portal hypertension, are more common in the subacute, that is after 7 to 21 days. So what are the take-home messages? Early recognition, common causes are varying, prognosis depends upon the cause and timing, and major guidelines are by the American Association for the Study of Liver Disease and EASL. ICU and transplant referrals saves lives. We'll discuss these things in later sessions. Thank you. Stay tuned.